Hi students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyasree, your OBG Guru. Hi students. So in this video, hi Akarshan, hi KP. So the question paper what we have, for the OBGYN, it's not like very difficult or neither it is very simple. So there were little twisted answers for the questions. Okay, let us see. And I think there were not many questions this time in the INICET pertaining to OBGYN. So let us see the questions and let us discuss about it. So first starting with the very good evening to all of you. Myself, I am Dr. Ramyasree, your OBGYN Guru. So we are going to do the INICET November recall. First question. A 58-year-old female presented with ovarian mass with ascites. Further investigation showed omental caking and peritoneal carcinomatosis. What is the management? See, now actually CA ovary is surgically staged. CA ovary is surgically staged, but they have clearly given that there is omental caking and they also mentioned that there is peritoneal carcinomatosis. Now they have identified peritoneal carcinomatosis. It means that already they have diagnosed CA ovary, right? So looks like already staging laparotomy is done. Now I have two things here. So actually all this should have been told by staging laparotomy, but I don't know how they have already mentioned that there is peritoneal carcinomatosis, omental caking and all, right? So they have directly asked you what is the management to be done. So what is the management you do for CA ovary? And when it has gone to the peritoneal, it is already stage 3. Peritoneal involvement is already stage 3. So CA ovary, I think you all know that we have already discussed so many times in your notes. So very simple management. If you have 1A and 1B or borderline, it is just cytoreductive or debulking surgery and no post-op chemotherapy. But when it is from 1C to 4, it is cytoreductive or debulking surgery plus 6 cycles of chemotherapy, either with cisplatin or carboplatin plus paclitaxel. As there is peritoneal metastasis, as they have already given there is peritoneal metastasis and looks like more only. So anyway, whenever there is extra peritoneal metastasis is stage 3. So definitely it is not 1A or 1B. So 1C to 4 it is cytoreductive or debulking followed by 6 cycles of chemo. So what is the answer we have here? Chemotherapy followed by debulking, debulking followed by chemo, debulking followed by radio, staging laparotomy. I believe they've already done laparotomy. That is why they could tell there is peritoneal mets and all. So directly you'll go for debulking followed by chemotherapy. Debulking followed by chemotherapy. Right? So the answer here will be B. The answer here will be B. Right? So let us see the next question. Let us see the next question. Which of the following has a risk factor associated with borderline ovarian tumor? Which of the following has risk factor associated with borderline ovarian tumor? So this again, I don't know, this exam you got like so many questions. There are 3 questions directly from ovarian cancer. I think this is pretty easy, no? Which of the following is associated with risk factor with the borderline ovarian tumor. You all know the more they ovulate, there is more chance of C ovary. So we have the list we have discussed many times again in the class. Early menopause, late menarche, short cycles, nulliparity, ovulation induction drugs like clomiphene or letrozole, talc and asbestosis exposure, and family history. So what is the answer here? OCP intake. OCP intake is protective. Functional ovarian cysts, they resolve by themselves. They do not cause ovarian cancer. PCOS, they don't ovulate. So actually they also don't cause ovarian cancer. PCOS very rarely goes into ovarian cancer if they are using ovulation induction drugs. So obviously, which is the risk factor which you feel is the answer here? Low parity. So the obvious risk factor what you're seeing here is low parity, right? This I expect all of you would have answered it correct. है ना? Next one. Which of the following has least risk of teratogenicity if contracted during pregnancy? Which of the following has least risk of teratogenicity if contracted during pregnancy? Again, this is something which we have discussed in last INICET also. You got a question on infections, to be frank. So, torch infections have the risk of teratogenicity, but herpes 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 is more is herpes vertical transmission? Does herpes cause problem if it comes in the pregnancy? Are you all answering? So we have herpes, rubella, CMV, varicella. So basically rubella will cause problem, varicella also will cause problem. Cytomegalovirus, yes, but herpes affects the fetus more during, it is a vertical transmission. So if we get herpes even in pregnancy, nothing we have to do. But if you get herpes in the third trimester, we always go for cesarean section. Why? Because herpes in third trimester can cause vertical transmission to the fetus. So if we get herpes during pregnancy, nothing to be done. We have to give acyclovir to the mother so that it doesn't cause any effect to the baby, and the herpes will go away. And during delivery, herpes will not transmit to the fetus. If you get herpes in the third trimester or beyond 36 weeks, the mode of delivery will be changed to LSCS. Okay. Yes, very good, Sneha. Excellent. Right, this also I'm expecting all of you would have answered in the exam. A primigravida presented with good uterine contraction every 2 minutes per vaginally. Cervix is 6 centimeters dilated, 70% effaced. Membranes are present with bag of worms feeling. What is the next step? So what do you think is this bag of worms feeling telling us about? So this bag of worms feeling tells us that we are dealing with cord presentation. We are dealing with cord presentation. What do you do when there is a cord presentation? So probably cord or occult cord prolapse. Cord has come down. So whenever there is a cord felt, don't touch the cord. Why will you do ARM to confirm the cord? Right? So you will shift the patient for emergency cesarean section. You will shift the patient for the emergency cesarean section if there is a cord presentation. Always remember, even if it is cord presentation or even if it is cord prolapse, you will go for emergency LSCS. Right? Okay. Next question. 13-year-old girl with pain abdomen Diagnosed at 12 weeks pregnant. What is the next step? Next best step. 13-year-old girl is a minor aged. So whenever you have a minor girl with pregnancy, preserve clothing, plan for MTP, take consent of mother and do examination, register MLC and inform police. So whenever you have a 13 year, less than 18 years, any children getting pregnant or there is any sexual act registered on the patient, you should always first register MLC and inform the police. So first you have to register MLC and inform the police, right? So this is mainly under the POSCO Act. So any children below 18 years, irrespective of the gender, if they have any form of sexual abuse, you have to first register MLC and inform the police. After you register the MLC and inform police, then you can go for taking the consent of the mother, because we take the guardian consent here. We have to do examination as well as we plan for MTP. But first thing is that we have to register MLC and inform the police. Yeah, it doesn't matter whether it is 8 weeks or so. First thing is that we have to register MLC and inform the police. Causes of blood volume increase before term: action of aldosterone and estrogen, retention of water by kidney, action of aldosterone and ADH, both action of aldosterone and estrogen and retention of water by kidney. Now we all know that blood will become pani pani in pregnancy. है ना? We have so many times discussed that blood volume increases in pregnancy. Why does this blood volume increase? This blood volume increases because of the sodium and water retention. You all already know that sodium and water retention is mainly due to estrogen. We write in the estrogen functions that estrogen causes sodium and water retention. Does alone estrogen, sodium and water retention will help in the raising the blood volume by increasing the water? No. You also have retention of water by the kidney. So usually the kidney secretes renin and prorenin, which helps in the absorption of water. So it is both action of aldosterone and estrogen and retention of water by kidney. So I assume this also you all would have written correct, right? So the answer here is D. Which artery forms anastomosis with uterine artery to prevent ischemia of the uterus during PPH? So indirectly he is asking what is the other blood supply to the uterus. Again, this has been asked as an MCQ so many times. Uterine artery, ovarian artery, arcuate artery, round ligament artery. I don't know whether the options are correct, but yes. So which is the artery? Which artery forms anastomosis with the uterine artery to prevent ischemia of the uterus during PPH? So uterus is supplied by both uterine artery and ovarian artery. Uterus is supplied by both uterine artery and ovarian artery. So I don't know whether this is a question, to be frank. So if there is a bleeding from uterine artery, I feel the most possible answer which is causing anastomosis is better to go for ovarian artery. So ovarian artery. But was this the question? Yes. So uterine artery anastomosis is ovarian artery. So normally we have the uterine artery blood supply. Second, we have the ovarian artery going into the, see, uterine artery branches are arcuate artery, radial artery, spiral artery, basal artery. So when uterine artery is bleeding, obviously this arcuate, all these are bleeding. So what is compensating for that uterine artery? It is the ovarian artery. So you have to tell it as ovarian artery. Okay. Yeah, I think this was an interesting question. A gravida 6, para 2, living 1, abortion 3. Female at 38 weeks gestation with history of 2 previous cesarean section and 3 abortions. What is the most appropriate? There is high risk of bowel injury due to PS. I think he is telling placenta accreta syndrome. See the possible what we have with two previous LSCS is accreta, percreta, increta. He should have written MAP, no, morbidly adherent placenta. High risk of bowel injury due to PS. High risk of bladder injury due to PS. She needs blood transfusion due to PS. Need for hysterectomy. Did they ask what is the most appropriate, or did they ask all of the following are required except? All might happen except. I think in this, in my Telegram group, they've told all of the following are complications. Okay. So question was, what will not be counseled? What will not be counseled? Okay. So again, we have discussed morbidly adherent placenta. Whenever she is multi, will you tell her the need of hysterectomy? पहले हम देखेंगे कि what will definitely be told to her. Then we'll try to come to an answer. See, this is the pattern of MCQs which you should be prepared also. You will not get everything same print to print. है ना? So you will tell her the need of hysterectomy. She's a multi. She had so many abortions, and this is again one more child. She already has one living child, right? So you will definitely tell her the need for hysterectomy. Whenever you have placenta accreta syndrome, we write in our notes also that we do hysterectomy, है ना? Okay, now next up. She needs blood transfusion due to placenta accreta syndrome. Yes, there will be need for blood transfusion. No, indeed, we cross match and keep 4 units of blood before placenta previa or morbidly adherent placenta, whatever we are operating. So she needs blood transfusion. Bladder injury. Don't we have bladder injury? We have the risk of bladder injury also. Actually, we do have risk of bowel injury, but risk of bowel injury is not as much as bladder injury or the need for blood transfusion or the need for hysterectomy. So I will not counsel high risk for bowel injury. I will not counsel for high risk of bowel injury. To be frank, this is one of the questions which I've seen in MRCOG preparation. So, nowadays, like a lot of those questions are being asked. Ha, to be frank, you would have been confused because of this PAS. To be frank, I do agree PAS क्या है करके. फिर भी मानो अगर हमें PAS, we didn't know what was PAS. Till then also you could have attempted based on two previous LSCS. So probably under there would have been full additions. So there are full additions. So there might be PPH. So अगर PPH होगा तो I will tell her I might do hysterectomy. I will do blood transfusion. There might be risk of bladder injury. But now what least possible I can expect is bowel injury. Actually, bowel injury can also happen, but not as much as the rest three. So that's why you will go for the option of A. Okay? This one, the next question is little disappointing if you would have not answered this correct. Clinical scenario in uterine inversion with placenta still attached. What is the next? What is the next immediate step which you will do? What is the next immediate step you do? Remove the placenta and reposition the uterus. Put the uterus inside without removing the placenta. Shift to OT and insert uterus back. Can you tell me what is option C? Separate the placenta first. First and foremost, if you remember, always in my class I'll tell you, once my intern has removed the has done uterine inversion. So then he has once, then he told, oh, such a big placenta, and he calls me. Do you remember I tell this story? And I always tell last, when the uterine inversion occurs, don't call anybody. First thing what you should do, push the uterus immediately. है ना? So can you tell me what is the option C? Shift to OT, insert the uterus back and placenta first, and placenta last, ki placenta first, and then remove the placenta. What is that? Shift to OT, under GA, reposition the uterus. Now, this is again a tricky question, to be frank. So, I think there was a midwife conducting delivery, and midwife has noticed the uterine inversion with placenta still attached. What is the next immediate step you do? To be frank, you have to shift to OT and push the uterus back under GA. If uterus have gone into that contracted state, you do modified Johnson's method when uterus goes into that contracted state. Okay? But if you have noticed uterine inversion just now, next immediate step, if the question I've asked, what is the next best immediate step when you have noticed an inversion, push the uterus immediately inside. Agar uterus has not gone into that contracted state, then what you should do? You should immediately push it back without removing the placenta. I tell you, no, third uterus also should not know that it has come out and it has gone inside. Itna jaldi, if you do it off, then if they've asked what is the next best immediate step, then push the uterus inside without removing. If they would have told that there is a uterine inversion, patient into shock, what is the best management you do? Then that is shift to OT and insert the uterus under general anesthesia. So I am not able to decide what should be the answer between B and C here, because I am not understanding the exact question what they have given in the, depending on the situation, the answer can be B or C. I'll reconfirm the answer of this question once I get to know the proper question here. Okay? Right, this is also a tricky question. I felt this was also a very tricky question. A patient was taking a DMPA. So patient was on DMPA injections, and there was a delay, and patient came after 14 days late for the next injection. What you should do? See, when patient comes 14 days delay, there is always a possibility of pregnancy. There is always a possibility of pregnancy. But even though there is a possibility of pregnancy, how can pregnancy be positive as soon as, 14th day he ovulation hoga? 14th day he somebody cannot get pregnant, and 14th day only you can see the UPT. Now is less likely, no? Is less likely, right? So UPT before DMPA, give DMPA whenever she comes, give next dose and have backup for the 7 days, come for the next dose. Now again here there are two options which you obviously can rule out. Come for next dose, nahi. Give DMPA whenever she comes, no. Ideally all contraception should be given within 5 days of the periods. So when somebody comes, you cannot tell I'll not give. When somebody comes, you cannot tell you will not give, right? So what you should do here, see now, but if you do UPT now, it will not be positive, obviously, because last cycle she has taken DMPA. Only thing is that this time she has come 14 days late, and with DMPA there is no immediate, the fertility is not immediately going to come back, right? Although she might not, I might not pick up the pregnancy, but before I give the injection, I have to confirm that she is not pregnant. So that is why I will do UPT and then I'll give the injection. And ideally, after doing UPT and then giving injection, you should also give a backup for 7 days. But I don't have both options combined. So if I have to choose between A and C, I would prefer to go with A. I would prefer to go with A. So do UPT before giving the DMP and then followed by you give the DMP injection. This is an easy question. Virilizing ovarian tumors with Rinke's crystals. Leydig cell, dysgerminoma, yolk sac tumor, serous cystadinoma. Virilizing ovarian tumors with Rinke's crystal. This is again very easy. Every time ovarian cancers, you should always revise the tabular form, which we have always discussed. That is the HPs. So Leydig cell tumor is associated with Rinke's crystals, and Leydig cell tumor is the one which has, it is the virilizing ovarian tumor also. So Leydig cell tumor produces testosterone, which causes virilization. So virilization, it can cause deepening of voice, male pattern baldness, breast atrophy. So there will be all testosterone producing ovarian tumors can be associated with virilization. So here virilizing ovarian tumor with Rinke's crystals is Leydig cell tumor. So here uh, virilizing ovarian tumor you have, and the another clue which was given was Rinke's crystals. Rinke's crystals is short for Leydig cell. So you don't have any doubt to not answer Leydig cell. Next question also I felt is easy. A girl with hirsutism and irregular cycles and more weight, mother is diabetic, serum testosterone levels 0.4 to 0.5. I don't know whether it is testosterone levels or what is it. What will be your management except? So in this question you had Sertoli cell tumor as a one option as well as you had arhenoblastoma as an option. Okay, then it becomes little difficult for you because Leydig cell tumor, arhenoblastoma and Sertoli cell tumor, all these are virilizing tumors. But was there Rinke's crystals? If you had Rinke's crystals, then you can close your eyes and answer Leydig cell tumor, because Rinke's crystals are seen very specifically for Leydig cell tumor. If the question gave Rinke's crystals, then your answer will definitely go to Leydig cell tumor. Okay? Okay. So I see that you are telling me that there are two different questions about the virilizing tumors. So you had one question which was telling there is a testicular tumor. So there was one question which was telling there is a testicular tumor with Rinke's crystals and Sertoli cell tumor, Leydig cell tumor. Okay, the testicular tumor with Rinke's crystal, the answer will go for Leydig cell tumor. Virilizing tumor had arachnoblastoma and what other options? There was no option of Leydig cell, kya? हाँ क्या?
स्टक हो रहा है मैम आपका वो वाला लैपटॉप इधर से भी। हेलो
हाँ पर स्टक क्यों हुआ?
मैम वो आपको इधर से इशू आ रहा है मैम। मैम एक बार वो अपना ना ओबीएस बंद कीजिए और लोनेट भी बंद कर दीजिए, एक्सेस भी नहीं ले पाता मैं। और कितनी देर का सकते हैं मैम?
लास्ट था।
लास्ट था।
Right. So one last question we had was a girl with hirsutism and irregular cycles and more weight. Mother is diabetic. Serum testosterone levels are 0.4 to 0.5. What will be your management except? So this is a classical case of PCOS. This is a classical case of PCOS because girl has hirsutism and irregular cycles. So she is fulfilling the criteria of Rotterdam's criteria of hirsutism and irregular cycles. so as it is a hirsutism, so this table which we have it in our notes. So irregular cycles with oligomenorrhea and secondary amenorrhea, we give OC pills. Obesity, we give metformin and OC pills. Insulin resistance, metformin. Hirsutism with PCOS also we treat with OCP and cyproterone acetate. Infertility, we give letrozole. Now here he is asking, obviously you will tell lifestyle modification for her. you will tell her lifestyle modification and exercise. You will give her OCPs also. Counsel for future metabolic syndrome. Yes, already her mother also got diabetes. There is high chance that she is also PCOS. She can get diabetes in future. So next, OCPs and anti-androgen drugs for hirsutism. No, for PCOS, OCPs works very well. That too OCP containing cyproterone acetate. So you don't require to again give anti-androgen drugs. So the answer here will be 3 OCPs with anti-androgen drug for hirsutism. What is the HPV vaccine made of? Now, no exam can end without giving a question on CS cervix. What is the HPV vaccine made up of? Again, this is not a first time. This is repeat question. So we all know that HPV vaccination is purified L1 capsid protein. HPV vaccination is purified L1 capsid protein. HPV vaccine is purified L1 capsid protein. So this is a purified L1 capsid protein. So the answer here will be B. Now if I analyze the entire paper, I'll tell you this is an absolutely easy question. You could have answered PCOS wala question also, 2 marks. Okay, this question you are telling there was a different answer, let's leave it. This is a difficult question, okay. This, so DMP and uterine inversion both were difficult. I think this you could have answered. This ovarian artery is a branch apart from the uterine artery is also many times known to us. This also you could have answered, that is blood volume ka, right? Regular MLC and inform the police, this you all know. When cord presentation, emergency cesarean section, this also we all know. Herpes simplex you can answer. Now, low parity you would have answered. So this also you would have answered. There were 2 to 3 questions which were little difficult, but apart from that all questions were possible to answer it, right? So if I have missed any question, please feel free to message me, I'll see it. And virilizing tumor may, was there any clue given between to differentiate between the theca cell tumor and arrhenoblastoma? Was there any clue given between theca cell tumor and arrhenoblastoma? Because both arrhenoblastoma and theca cell ovarian tumor both will cause virilization. So there should have been definitely some clue against each other, no? So was there any clue given between theca cell tumor and arrhenoblastoma? So that you can think and message me. That you can think and message me. So thank you guys. So all the best. Keep studying. Okay. So there was one question on abruption. Can you tell me what was the question, Prajwal? With absent fetal heart rate. Okay, what will you do when there is an abruption with absent fetal heart rate? Will you go for what? Did they ask the management? Did they ask the management? What were the options? So uterus was tender, high blood pressure, proteinuria, vertex -3. What is the management? What were the options which we had for management? So basically it is a severe preeclampsia. Looks like a case of severe preeclampsia with abruption. So one is induction, second wait and watch, third antihypertensives and cesarean section, 34 weeks. Any other option? So the answer for this should be, so even if you have, whenever you have abruption, again abruption is something which is commonly discussed in our exam, in our classroom, and I tell you most of the abruption have underlying hypertensive patients go into abruption. So 34 weeks abruption with a dead fetus, tender uterus, but so it means it is just grade 1. So whenever there is a dead fetus with abruption, what should be the mode of delivery? We go for vaginal delivery. Why will you go for cesarean section when there is a dead fetus? So you will go for induction of labor. Yes. So it would have been, you have antihypertensive and ARM. Was there an option of induction or antihypertensive and ARM? So you will augment the labor and you will deliver her. You will augment the deliver, augment and deliver her. So I'm not getting again the proper options here. So they have given it is an abruption already. Then you don't, if it's normally for a dead fetus, we don't do we don't do ARM. So for a dead fetus, usually you should not do ARM. If it's a dead fetus, ARM is contraindicated. But here, cesarean section should not be done. As she is already gone into abruption, you cannot do wait and watch. If you had an option of induction of labor, you can go for induction of labor. I don't know how much is the blood pressure. High blood pressure matlab kitna blood pressure. If it is very high blood pressure, then then your better answer will go for antihypertensives and ARM. Because the advantage of ARM is it will augment the labor. Antihypertensives will prevent convulsions or will decrease the severe blood pressure in her. Yes. Okay, 166/94. So whatever options you have provided to me, the best answer will go for antihypertensives and ARM. The better answer will go for antihypertensives and ARM. Because 166/94, you first have to stabilize her blood pressure, and then you go for augmenting the labor. For abruption, you can augment the labor by doing ARM. So you can go for antihypertensives and ARM, but not cesarean section. But not cesarean section. The only thing where we'll do cesarean section for abruption is when there is fetal distress, right? So that's about the INICET recall. So I'll see you all. Thank you so much. Any queries or anything, always feel free to message. You can tag me with my name, Dr. Ramyasree, on DBMCI Telegram group or DBMCI Facebook Premier group. I'll be available to answer your queries. Thank you guys. Good night. Sweet dreams. Don't think much about this. Learn from this exam. Continue your preparation.